going to be marginally useful. So he gave me this rather provocative title, and I'm going to do my best with it, without, I hope, being too provocative. I think the first thing that it is essential that policymakers remember is that scientific medicine does good, but it also does harm. And an uncritical approach to the benefits of modern medicine is potentially harmful. So, as I said earlier today, this is my diagram with which I attempt to understand my life's work. And for general practice, the important interface is the red one, between illness and disease. This is the referral one, which everybody thinks is the basis of the cost effectiveness of the health service. The flaw in this diagram is this box is much too big. But if you make it so as it should be, you can't fit it right. But this is the crucial part, and that's crucial because stressful life events cause symptoms of illness without disease. So you can have an anxiety attack because you just bumped your car. That can make you feel very shaky and strange. You know, so life events can cause symptoms. So you know, somebody who's been sexually abused is highly likely to develop pelvic pain. It doesn't mean that a pelvic operation is going to help them. Positively the reverse. So, and in today's society where we don't have religion to help us cope with life's difficulties, not as many of us do anyway, we don't have much grasp of philosophy in day-to-day's events, then illness is one of the few valid outlets, and the healthcare system is one of the few valid places you can take distress in modern society. The mistake is if unthinkingly you interpret distress as disease. And so general practitioners have learned over the years the importance, both for society and for individuals, of holding this borderline here, and only giving people a disease label if it's in their interests to have a disease label. If you think that putting them in that category and giving them an approved treatment will provide them with an advantage. Now, clearly this bit is very important, where you articulate primary care services with secondary care services. So in any system, that articulation is really useful, and I talked about that earlier today, the history of that and where it came from. And the reason it works so well and is so important is actually in this diagram, which is a bit of a challenge, and I had a pointer earlier on, but it seems to... No, it's long since disappeared. But you also, this is about the predictive value of tests. And you can see, down here is the prevalence of a condition in the community. Now, general practitioners work in low prevalence communities, where for the same test, with the same sensitivity and specificity, you get a very low positive predictive value. Such a low positive predictive value, it's almost useless. When you've got a high prevalence population, then your tests work. And one of the things that primary care does is to, by very subtle processes, because how we ever get anything right, I have no idea, but what we do is we manage to select a high prevalence population for our specialist colleagues to work with, and then their systems work robustly. And the problem with, and I visited a lot of healthcare systems around the world, where patients have direct access to specialists, then specialist services become less effective because the tests don't work so well. This is another warning. There is a tendency in the world, encouraged by the medical industrial complex, to widen the definitions of diseases. So during my and Mike's professional lifetime, the thresholds for diagnosing high cholesterol, for diagnosing blood pressure, for diagnosing obesity, and for diagnosing diabetes have all shifted. And they've shifted to include more patients. And this is a very nice study. It's an old study now, as you can see from the dome. Shows what happens as these definitions were shifted during the 80s and 90s And what happens is, as you shift from these thresholds, so when I first qualified, high blood pressure was 160 over 100 and above, and it's now 140 over 90 and above. And you can see the differences, though they're using American digits, for units for the sugar and the cholesterol. But this shift produced overnight 32 million more patients. And that shift made 3/4 of the American population to have one of those 4 conditions. So that's not, bears no relation to symptomatic illness. So you've got a disconnect between disease and suffering. And how much do those trends really reflect the needs of our patients, and how much do they reflect the interests of the industrial side of the healthcare system? And it's this thing called the Will Rogers effect, named after the American comedian Will Rogers, who cracked this joke. So when the Okies left for Oklahoma and moved to California, they raised the average intelligence in both states. I'm sure you have the same sort of joke about Jersey and Guernsey, because that sort of joke has been replicated. But Feinstein, the great American epidemiologist, as long ago as 1985, described the Will Rogers phenomenon in the New England Journal of Medicine. And the phenomenon occurs when the range of biomedical abnormality is extended. So as more and more people previously considered as normal are included within the definition of, for example, hypertension, diabetes, the outcomes improve overnight. Rates of hypertensive stroke fall, rates of diabetic foot amputation fall, or appear to fall. So you create the illusion of improved outcomes, very seductive to both policymakers and clinicians, but you have done nothing at all for the affected individuals. So you can create havoc with statistics, and you just need to be wary of those. And I think at the moment we're seeing exactly the same phenomenon happening with breast cancer. We've widened the definition. We thought all this early diagnosis through mammography was probably not going to do anything in people's lifetime. And lo and behold, we have a better survival rate. Mortality rate? No. But survival rate, much improved.
Can I just ask, have the UK massaged the figures the same way as America did?
Yeah,
They did?
Yeah, we all did. You'll find you have too, I suspect. Because there's just been a downward drift, hasn't there, Mike? It's just drifted downwards. And the expectation, so for example, in the Quality and Outcomes Framework in the UK, it's fallen straight into that by using these sorts of thresholds. And you I'll tell you about this example, which is similar. So this is the 2003 European Society of Cardiology guidelines, taking, as you see, the blood pressure of 140 over 90 and the serum cholesterol of 5 millimoles per litre, which is, I think we work on 5.2 in the UK, I think maybe. So very slightly higher, but these, and it's probably not irrelevant that the huge panel of European experts who devised these guidelines, every single one of them has some sort of connection with the pharmaceutical industry. Just something to watch. It's rather hidden in the paper. You have to go down rather a long way. Now, fortunately, researchers in Norway had this data for the entire adult population of a single Norwegian county, Nord-Trøndelag. And when they plotted this, this is what you get. The rate of, so these thresholds are supposed to define people at increased risk of premature death from heart disease. You'll notice that the rate reaches 50% at the age of 24. Okay, 50% of 24-year-olds in Norway are expected to die prematurely of heart disease. And overall, 74% of the entire population are deemed to be at premature risk of heart disease. Very similar to the 3/4 we had of the American population included in those, which is interesting. You're not supposed to treat at these thresholds necessarily. You are supposed to advise these people that they're at increased risk. So you tell them they're increased risk, you frighten them, and probably undermine their health in that way, because, of course, it's important to remember that Norway is one of the longest living populations in history and has an average life expectancy at birth of 81 years. 50% of 24-year-olds cannot be at increased risk. There's something very wrong with the thresholds we have allowed the medical industry to set. So this is a way, and the reason this really matters is it becomes a license to print money. This is a very nice paper from the Australian journal, which on the, I can't do my left and my right, on the left you have conventional medical treatment of a disease. Fortunately, with a disease, people mostly have symptoms. So you give them a treatment, you have responders, it works, they're helped, you continue the treatment. You have people who don't respond, you stop the treatment. Pretty cost effective. If you're treating risk of disease, which blood pressure, cholesterol, weight, they're all, even diabetes, type 2 diabetes is a risk rather than a disease in itself anyway. The outcome is probabilistic, it's statistical. So even if the disease was prevented, even if it is not prevented, and even if it was never going to develop, the treatment continues indefinitely. It is no wonder that pharma industries are investing more in preventive technologies than in treatment technologies, because, as I say, it's a license to print money. So that's just a little bit of warning about how easy it is to be manipulated into thinking that you have serious health problems as a community when you don't. But now to come on to the really serious health problems, and these are adverse child experiences. I'm talking about the Adverse Child Experiences Study, which is a collaboration between Kaiser Permanente in the United States and the Center for Disease Control in the United States. Biggest study of adverse child experiences ever undertaken. And these are the adverse child experiences they count, that they were studying. So you can see all of these: an incarcerated household member being sent to prison. So you've got the list, and every single GP will have patients who have been subjected to one or other of these. And people with come to this, but these have a really serious effect on health, and it seems to be to do with the effect of these sorts of stresses on the developing brain. And there's a paper to be published in the BMJ tomorrow, I think, no, Monday, with yet another genetic change that happens seems to be caused by stress, pre-birth. So children's DNA is altered by stresses during pregnancy, which seem to have a pretty an effect that's pretty difficult to reverse. This is a wonderful book, The Lived Experience of Violation. This is a Norwegian author summarising this: children who more than anything have learned that they are worthless, often the result of those sorts of adverse events, and not appreciated, turn into young people who know neither their right to be protected nor how to protect themselves. And this is the pyramid from the study. So you start with adverse child experiences at the bottom. You get definite evidence of physical changes in the brain, disrupted neurodevelopment. Then you get social, emotional, and cognitive impairment, which leads to the adoption of unhealthy risk behaviours, so excessive drinking, smoking, drugs, physical risk-taking, driving, leading on to disease, disability, and social problems and early death. And the problem is that we try to intervene at the level of the adoption of health risk behaviours, which is far, far too late, and what we need to be doing is investing in young children and pregnant mothers. If we're really serious about doing something about all this. So this is just dose response to adverse child experience and the risk of heart disease, all of them individually with the risk, and cumulatively they add up. So the higher the experiential load early in life, the shorter the life expectancy. So if you have 6 or more adverse child experience, you die on average 20 years earlier than somebody with no adverse child experience. It's an extraordinarily powerful predictor of future health. And then just my last topic, clinicians and policymakers are meant to disagree. We have different priorities. As policymakers, you have to prioritise the needs of the population over the individual. As clinicians, we have to do the reverse. We have a responsibility. So there will always be a tension. It's pointless trying to get rid of it. We have to work with it and exploit both sides of it to use it optimally. And it's all about also our responsibilities, not only as patients, but as citizens. You know, all of us are citizens, just a few of us are patients, but our attitudes as citizens, in relation to things like adverse child experience, our attitudes as citizens both create patients and then pay for their treatment. And the other one is, this is another completely intrinsic tension. The desire for policymakers to have bureaucratic and political control and accountability of what is going on in their services. Entirely understandable. But needs to be balanced against the need, the professionals' need, the professionals' morale, autonomy and self-respect. We have to hold these things in balance. And it's so easy to tip over once you start with bureaucratic and political control, so that actually you end up with enfeebled professionals that are not in a position to properly help patients. So I've got 2 more slides. Central prerequisite for a decent primary care service: universal access, registered lists. We don't have any registered lists in Jersey at the moment, as far as I understand. Very difficult to know who takes the ultimate responsibility if patients don't know who the doctor, don't have a named doctor who's taking the ultimate responsibility. And interesting experience in Norway you might like to look at, where about 10 years ago they moved from a system like yours to a registered list system. It's been a big success. People have voted for the doctor they wanted. And GPs have to be the first point of contact. You have to get your diagnostic skills right up front, otherwise you're going to miss something. Primary care must focus on people, on the individual person, not on the diseases. And you need continuity of care, which I understand is not a problem in Jersey, and you're an example to the rest of us in that respect. The threats are the commodification of healthcare. Partly with this is Andrew Lansley could give you an object lesson on how to commodify the health service. I won't go there. Co-payments. The worry about having a system entirely based on paying primary care for patient attendances, then the perverse incentives that sets up, and the way that we have clear evidence that any sort of payment disadvantages the poor, worsens your health inequalities. I mean, you've got not a very impoverished society here, but I'm sure you have pockets of poverty. Every society does. These people will be disadvantaged by co-payments, either to attend hospital or to attend. And we know that that makes it worse. And loss of continuity by disrupting and introducing different people. I'll just touch on the problem of having, I understand there's been some talk about having specialist nurses, COPD nurses and heart failure nurses, and running around the community. And the problem with an ageing population is that people will tend to have COPD and heart failure. And what happens then, and it's happened in the UK because we've been down this path, is the patient then gets visits from 2 nurses who have conflicting ideas because they're following one guideline, and the poor patient is trapped in the middle. And primary care, generalist physicians need to be supported by generalist nurses. I think I'll stop there. Michael, carry on. Yes? Are you going to just say a few words?
I was going to. Yes. Good. Thank you very much, Iona is the mistress of the sudden finish, taking everybody by surprise. That was good. So I haven't got a presentation. I was asked to do one, but I've got one. But I'm not going to do it because what I want to do is just tell you a few things that have come up during the course of the day that I think may be of value to you. The first thing is around revalidation, which is my specialist subject. If ever I was to do mastermind, it would be the history of revalidation, which has been going on now for just over 12 years. And I think I know every twist and turn of the agenda, but we're now in the last circuit, we hope. And it should be coming in at the end of the year. Now, having talked to people about the position you're in, I have one or two things I think I need to suggest to you that you need to think about quite urgently. One is to make sure you have your responsible officers as soon as possible, and that they are properly trained and supported to do the role they're going to be expected to do. If you do not have your responsible officers, your doctors cannot revalidate and cannot continue to work as certificated doctors. And they are going to be absolutely crucial, not just for your doctors and making the standards clear and making sure that you have revalidation that works, but actually for prompting the system to do the other two things that you will need to make sure you've got if you're going to have effective revalidation. The first is good appraisals, fit-for-purpose appraisals. Now, in general practice, you have them because they've been linked up with the Wessex area, and you've had appraisers coming into general practice. On my sample of 2 hospital doctors I've spoken to today, neither had an appraisal at all, and both were expecting one within the next year. Well, in the UK, every doctor who's a consultant has had an appraisal for at least 3 to 5 years. And we've got some catching up to do in Jersey. It's not too late, it's not, it's not a crisis, but we can't afford to let that run because we've got to get everybody. And the doctors in the UK who've missed out have been the peripatetic locums in general practice, and we're really having to work hard to get them into the appraisal system effectively. And then the staff grade doctors in secondary care. And so it's easy to pin down the consultants, the GPs, quite easy to get the people in training, but actually the staff doctors are often forgotten, and I have to say they're the people who we should be concentrating on first and foremost for appraisal because they're a very important group. And then the last thing about revalidation is the need for effective clinical governance systems. Now you have a stunning, absolutely stunning prescribing information system from general practice, really impressive, and that's an example of how information can help to inform a discussion around variation in care. And quite clearly, there are, having seen the data, it said not to be copied to anybody and confidential only, and yet I managed to see it. But that document quite clearly shows that there are some doctors who have got some very unusual prescribing patterns. Now, there may be some very good reasons for that. So it's not a matter of saying, oh my God, there's a variation, we must beat them up. It's a matter of saying there's a variation, let's see if there's an explanation. And so you've got some very good examples of clinical governance, but there are many ways in which clinical governance can help to inform the health service, yourself as policy makers, but also, very importantly, the RO and medical directors who will need to have access to good quality information to ensure the safety of your population. So clinical governance, I'm no expert, but from what I've heard, it's good, but needs to go a little bit further in order to be able to be fit for purpose for your population. So those are the issues around revalidation I just wanted to draw to your attention. The second thing I just wanted to mention was around about information, data flows, and around the definition of quality. And it seems to me that one of the great strengths of your general practice is that you've got information systems out there in the practices. They are using computers. There are 1 or 2 practices that haven't yet, but they're talking about having a central file server, managing to get all the data, and we've got the manager of the project here. And so it is very valuable, we've discovered in the UK, to have those sort of data in order to begin to understand the sorts of areas that you've got in your quiff, but also lots of other areas to define the health needs of your population, to understand the level of care and the outcomes that you're achieving here, and to compare them with other areas. Now, this is not an advert, but one of my roles, I've got many roles, one of my roles is as the strategic director of an organisation called Primis, which is funded in the UK, in England only, by the Information Centre to promote the quality of medical records. And what we do is we look at, the health practices look at their quality, we train them in what quality means, and then we help to run queries within the practice so they can see how the quality of their data compares with other practices, and then to look at the prevalence of their diseases, to look at their quality markers and everything else. And what that is a way of helping the general practitioners, first and foremost, to understand the quality of their medical records, but then to begin to share them on a website we've got called Chart Online, where they can begin to compare their performance across. And then, of course, policymakers can begin to have much more confidence in the data, because the practices are working themselves to get the data quality up and to get it more appropriate. So there is a whole agenda around electronic records, data fit for purpose, and having the right sort of support to make sure you have information which you can use to make rational decisions about the provision of healthcare and about the quality of healthcare that you're experiencing. And then the last thing I just wanted to talk about, because it's come up time and again, is the way in which we can start to look at the GP contract and the way GPs are remunerated and the way in which the health service works, in order to try and get what I believe is your great opportunity, which is you've got 100,000 population, you've got a big spend like every society has on healthcare, and the question is, are you maximising your efficiency and your outcomes for that? And while you've got general practitioners out there who are disassociated from the system, you've got the hospital in here who are offering free care, and you've got to pay out there, but you've also got the social care system. You've got an extraordinary opportunity here to try and engineer a system where all three parts are working together on the same agenda. And because you've only got 100,000 people and maybe 300 doctors or slightly less, the potential for actually getting that sort of solution is so much greater than it is in England. Now, one of the phenomena that we really irritate us in England is that whenever we come up with an idea and fail to implement it, Scotland always got there first and implemented it well. How come Scotland can do it when England can't? And the reason is, in Scotland, they can get every important mover and shaker in a room and they can get them to agree. In England, if the North East thinks it's a great idea, London won't. And it just is a quagmire of sides, right? And Wales can do it just as effectively as Scotland, but they just don't tell the world so much about it. But Scotland are very good at telling us how good they are. Now, if Scotland can do it better than England, Jersey can do it so much better than Scotland. And you can get all the movers and shakers together. Now, to come to the GP contract, Iona's mentioned the perverse incentives that exist when you have straight payment for visit, for face-to-face contact. In and of itself, that is not a disaster. But it's the fact that it's on its own as the only mechanism for remuneration of primary care, which is the perverse incentive and the difficulty. And there are many other ways. Now, I have to say that one of the ways in which you could really transform your health service is to reduce the proportion that patients have to pay for primary care as against the £19 that comes from the state. But that may be unaffordable, right? But actually, I don't want to go on to the other alternatives without mentioning the fact that while you've got that large co-payment from the patient as well as the payment from the state, then you're always going to have a problem because we've got to finance from patients that proportion of the cost of primary care. Now, I have a belief, and you would expect it from me, because I'm Professor of General Practice, ex-chair of the College of General Practitioners. I have a belief that actually what we've done is taken an old model from way back when the hospital was where all the real caring and the real curing was done, and general practice was where we just did talking and not a lot of therapy. That was the era of the 1920s, 1930s and before. And we're now in a position where the real care and curing of the population occur in general practice. All the drugs, virtually every powerful drug that's available in society is available to the general practitioner. All the services that a general physician offered in a hospital of 20 years ago are now available in general practice. We've got a few investigations, which we're not allowed to do in England, but maybe not the case here. But that's changing, and more we're able to access all the investigations that you do in hospital. So actually, the way in which you should be conceptualising the health service is to say that general practice is where the real saving of life and care gets done, but it needs the specialist service, that box that Iona was referring to, in order to be able to deal with the small number of people who need that extra care that happens just in here around us. And what we've done is we've unbalanced the health services in most of the United Kingdom, where in fact what we have is a concentration of hospitals, and you've got primary care, if you like, as the poor brother, where people have to pay rather than free. You know, if I were to be provocative, I would say you would be far better off providing free primary care and charging people going into secondary care than you would be for doing the way you're doing, and given the health service, the way it's evolved and the way it is now. So, what we would want to say to you, and I think it's our collective view, I hope, is that you need to look at a number of ways of funding primary care which incentivise a number of behaviours that you want to achieve. Now, I believe you need to be able to give some sort of straightforward incentive for primary care to employ primary care nurses and to extend their teams. You've got the great privilege of having one general practitioner for every 1,000 patients, whereas it's 1,800 in Scotland and 1,900 in England. So you've got a great opportunity. But if you make your general practitioners do all the things they do, if they are syringing ears and if they are taking bloods, then they are not doing some of the things that you really want them to do, which is about helping your population to become healthier. So what you need to do is look at what are the things that is really appropriate for a doctor to be doing, and trying to incentivise a team approach to the things that other people can help them to do in the community. So one thing you need to look at is some payment systems that incentivise those behaviours. Secondly, by all means look at quality, by all means look at the QIF, but don't make that as central to the financial system as they did with the British contract for general practice. It distorted behaviour. People began to concentrate on the QOF areas and to make sure that that was their priority in terms of organising their practice and delivering care. Now, the QIF and the QOF areas are important. I'm not decrying them. But because something's measurable doesn't mean to say it's the only important thing in town. And actually, as you must know from your own personal experience in health services, time, the skills of the clinician you're in front of, the way in which your pathways of care, the way they organise your care, is absolutely crucial to you. That is almost the most important thing. Did I have eye-to-eye contact? Did I have someone who empathised with me? Did they listen to what I was saying? Were they a caring doctor? None of that appears anywhere in QOF. Right? So don't let's fool ourselves that that's the only game in town. So use QIF and to allow practices to look at where their quality markers lie in that formulaic way. But don't believe that's the only dimension of quality. So what I'm saying is there are a number of ways you can give practice payments, direct core payments. You can give items of service. You can give fees per visit. You can give a whole range of quality marker payments. You can start to incentivise various services and pay for them. And one of the things that you might want to look at is what it is you want to move out of secondary care into primary care. What are the things that in 20 years' time you really don't want to be paying for in this hospital? And look at those and say, well, how can we incentivise general practice to do those? And let me just take a straightforward example. If a patient needs minor surgery now, they get referred up to the hospital. Why? Because that's free. The patients don't want to pay for another visit to their doctor to have it done. And actually, the fee doesn't cover the cost of that service in your primary care system. So if you want to take away a lot of the minor surgery, a lot of the dermatology referrals, all those sort of things, then you have to put in some way of transferring that money from the secondary care sector to the primary care sector. It will be cheaper in the end, but you need to find a way of incentivising that. So it's about defining what the services you want and then finding the right mechanism to bring them into the right environment. Because at the end of the day, where I started, if you have a primary care strong base service, it's the Barbara Starfield work, if you have that, you will end up by having healthier patients. You will spend less because you will have less money going to secondary care, more into primary, where it is cheaper to deliver. You will have happier patients because they have much more continuity. Care is delivered closer to them. It's of a higher quality. They get better communication. They understand their care better. They're involved in their care more, and you will end up with a healthier population. That's the promise. So begin to look at your health service and say, how can we achieve that, and what are the contractual circumstances to achieve that? Thank you. I'll stop there, but anyway, we'll have it to see.
So for now, we should just have comments.
Yes, comments, and Iona will take the questions.
Comments, positive, hostile.
Can I just ask,
Yes.
you did, Iona mentioned in her presentation, both of them were very good, about the tendency to expand and extend thresholds and the definition of disease, and be cautious about that effect. At the same time, you're telling us, quite right, probably, that we need to be passing more to GPs and placing a greater responsibility on them to support our population. I suppose my concern is, how do you achieve all of those quite correct aim objectives whilst having some form of confidence that the GPs themselves aren't exploiting the expansion of disease thresholds and treatment and so on and so forth for their own gain?
By having systems of payment so that they're getting their payment from different streams. So at the moment you've got this single payment system. Patient comes to see them, they get payment. And that's the only payment stream. Every single system of paying a doctor sets up incentives and perverse incentives. If you've only got one, you've got nothing to counteract the perverse incentives. But there are different ways of. We had a European symposium some years ago about this, and the consensus was you need multiple income streams for GPs. You don't put all your eggs in one basket. So if you have a salaried GP service, then you encourage GPs to work very short hours and to sit there and to minimise patient contact as much as possible because they're getting their salary and they might as well not work.
So they put up barriers to access.
If you have your system, GPs are encouraging, they need to encourage people to come in. The lower the blood pressure threshold is set, the better, because the more patients they can create who will need to come and have their blood pressure checked, all across those things I've just mentioned. So you've got that incentive. So you can already see that these two counteract each other. So if you had a bit of salary, a bit of basic practice allowance, we would call it, and a bit of on contact, then they balance each other. If you have, if you were to move towards a responsible doctor system, not responsible officer, but a named doctor responsible for each patient, so that nobody fell through the seams of your system, then you could have a capitation payment, which could be higher for children and older people, which would be a payment for care over a year. And then you see you have another set of systems. You've got the chance to plan care over a year, to try and rationalise it to involve other members of the primary care team in your care, because it's not to do with the doctor contact. You could have some nurse contact, but that payment would. Do you see what I mean? And then you can have payments for the big change in the early 70s in the UK when we moved from doctors working alone to primary health care teams. And I suspect we've overdone it, like everything swings too far. But was then when it was offered that with a practice nurse, you could employ a practice nurse, and 75% of it, of the salary, would come from the health authority. Huge incentive. You own for GPs to take on nurses, because they only had to pay 25% of the salary, but they got 100% of the time, and that produced a really big and rapid shift. And it's I would caution caution against going to nurse practitioners because I think that's an expensive one to get nurses. I think it's important to look at healthcare assistance you can offer an enormous amount of help to general practitioners who are just doing mundane living stuff.
Yep.
Are you able to point to a current model, whether it's in the UK or elsewhere, that you believe actually provide the best mechanism to achieve what you've explained to us this evening?
I think they always have to be being gently tweaked. You know, you get it right, and then people start. You know, doctors are very canny. They can squeeze. You know, if you ask doctors to jump through hoops for money, they'll jump through hoops for money. So you'll find that you set up a system, and it's pushing and it's unbalancing one way, and you just need to come back with a bit of a tweak, not a complete. You know, just lower this sum, increase this sum. And that's the great thing about having these multiple sources. If you want, for example, if you think that not enough, what can we say, not enough...
minor surgery has been done in general practice.
practice.
You change the way in which that is incentivised. So it is about being clear what it is you want to achieve and then looking at the contract to see how you can get behaviours to move in those ways. And in fact, you know, when they changed the new contract for GPs with the QOF, that for everybody involved was their best effort to try and get the right behaviour pattern. Now we quickly realise that some of it wasn't ideal, so they go back and negotiate and change the mix. But it is a matter of always being aware of what it is you're trying to achieve. And I guess here you're trying to achieve a movement of care from secondary to primary, and you're trying to improve the scope of primary care at the same time.
Are you suggesting, sorry, one last one for Chris, are you suggesting that we should emulate the UK model, or is there another model based on the similar system that you've just explained
I think you should.
that actually we could better learn from?
No, I think Norway's a good, interesting small country. Very interesting. Denmark's very interesting. And the Netherlands. All do things in slightly different ways. All have very strong, very successful primary care, very successful on Barbara Starfield's terms, in terms of you know, good health equity.
Thank you very much.
Yeah.
Thank you very much. I think it's been very interesting, and you find that you've had a good day. I hope you've had a good day with the GPs.
Mm-hmm.
I think so.
Yeah,
It's been very interesting for us.
We've
We've had a good day. I don't know whether they've had a good day.
And I just think your last point that James picked up too, and picking bits from Norway, but I'm sure it's important that we do it, so to speak, our way too.
Yes, exactly.
Yeah.
And
The
that's-
last thing we want to say is do it
You are
the
where
UK.
you are. And one of the reasons why I wouldn't advocate necessarily you abolish completely patient payments is the patients have grown to accept that. But what I think you need to do is make sure that the patient payment system is not so predominant that it, for instance, extends health inequalities. So,
Or pushes people to A&E.
or pushes people into A&E, which is what
We've got now.
which they're doing at the moment. And so making it, trying to focus that payment system on the people who can afford to pay and don't mind paying, more than on people for whom it is a real incentive to go somewhere else for healthcare, or not to have healthcare, which is, of course, the worst of all options, then that's the way to try and tweak that system. So, and there are many people in England, for instance, who wish there was a payment for care because it would be one way of controlling demand. But if you have that as your demand control, but people are so wealthy they don't actually regard it as a payment or a serious payment, and if the GP has an incentive to get people back time and again because that increases their income, then, we have heard today that there are some GPs maybe earning a reasonable income from as few as 200 patients. Well, if that were the case, I don't know, but if that were the case in Jersey, then that does mean those patients are being grossly over-serviced. And this comes back to Iona's point, is healthcare can be quite destructive if it's not managed well. Too much healthcare is bad for individuals. Right? It medicalises them, it takes away their capacity to look after their own health, and it means they see themselves in a dependency role and they lose their autonomy.
Yes, that's what's strange, perverse, it's incentive. to refer patients to secondary care, that we pay for a referral letter to.
Yes. And you have to go through that system in order to get into secondary care, unless you go to A&E at 3 o'clock in the morning.
I just hope that 200 was absolutely popped out the air. We don't absolutely know
Well,
what's the case at all.
sorry.
It could be way off the mark.
Okay, but very low lists, because we know that if the average is 1,000, some people have got nearly 2,000. So there must be some people with very low lists, and whatever that low list is, if they're making a living, they must be able to. No, I'm sorry. So but you need to start looking at it like that, because over-servicing is as dangerous as under-servicing, and that's one of the lessons we've had from the States.
How will you ensure not to replicate what allegedly is happening in hospitals with hospital nurses who've risen above what are termed the more mundane duties? How will you ensure that doctors don't do the more prestigious or status things and the practice nurses are running around doing the so-called routine things, thereby destroying the what you might call the bond that often exists between a doctor and a patient, even though sometimes it spills over into priestly work or social work. It's often seen as integral to the relationship.
Well, I mean, it's very interesting. I suspect you won't be able to get enough nurses to get into that situation at all. And remember, nurses are not taught to diagnose. Nurse practitioners have some teaching, but only doctors. I mean, the prime skill of a doctor is diagnosis, nothing else. Unless you're talking about surgeons and people with technical skills, but the prime skill is diagnosis. So you have to try and keep the doctor on the front line. But nurses are a million times better at doing a lot of aspects of care. Anything that involves a dressing, you only have to see a doctor trying to put on a plaster to lament for the future of healthcare. You know, there are some situations in which doctors are completely hopeless. And there's a very nice situation in Finland where they designed a health centre in Finland with adjoining consulting rooms, and you're registered with a nurse-doctor pair. Now, I don't think you'd ever be able to get enough nurses to do that. But they work in tandem. When the doctor's not there, gone on a course or something, the nurse, so there's always one of them present. So they've always got one, and they've got these joint consulting rooms. It's like those shared hotel rooms. You know, they've got a door between as well, so they can run between asking each other's advice, because the nurse has much more skill about anything to do with wounds, a lot of stuff to do with chronic disease management, certainly to do with excessive, venous pulses. There's all sorts of things that nurses do much, much better than doctors. So they work as a little team around the patient in a bigger setup. So there are ways of doing it. And we've worked with a lot of nurses, and the problems, I think it's been one of the successes of UK general practice is working successfully with nurses, generalist nurses, practice nurses. Working with these specialist nurses has been a bit of a nightmare.
A little bit of a controversial one, but I think it's something that probably needs to be. Can you comment a little bit on what we're discussing about the responsibility of an island to provide long-term stability of primary care from the point of view of pension and suspension and things like that?
Yes, we again, it's this single financing system. So worry that, I've just retired, and I'm a firm believer that one should quit while one is ahead. Quit at the top of your game. Don't hang on as a declining force or brain. The worry is if you've only got this system of payment with people coming in. Say your patients are beginning to think that you're past your sell-by date, and your practice number of people coming to your practice is falling off, then your goodwill, that I understand, is going to be falling off too. So your financial prospects are falling off. So the worry is that incentivises people to stay on longer than they should do because they don't have any option. Very bad to trap people in a situation where they're sort of encouraged to become less optimal. So to that extent, this notion, that the hospital doctors in Jersey do get a pension, but the GPs in Jersey don't get a pension because they can sell on their goodwill. You might want to think about, again, the incentives and perverse incentives that sets, and whether actually some sort of buffering arrangements to enable GPs to retire with dignity than they should might be worth looking at. Is that what you're getting at?
One final question. You did, as they speak about this expanding threshold and the risk involved. You then went on to speak about the adverse child experiences, and you identified quite a lot of this, which most of us are probably well aware of. And you're linking those directly with unhealthy adults or children. And then you went on to say, right, but this needs to be addressed at a young age. I suppose the question I ask you is that, isn't that contradictory to your comments about lowering thresholds? Because on the one hand, you're promoting lowering thresholds in dealing with adverse impacts on children, and yet on the other hand, you're saying, oh, but when it comes to other medical conditions, there's a risk in expanding those thresholds.
They may seem incompatible or conflicting, but they're actually they're not incompatible. And let me try to reinterpret, I think, what Iona was trying to say. It's not just about childhood experience. We know that in utero experience affects the size, the weight, and the life expectancy. Right? So mothers who have drug problems, alcohol problems, malnutrition, who have violent partners, who have life stresses in utero, right? And that evidence is very secure. We know that that's the case. What this is extending is saying that actually what happens in the formative years after birth are also incredibly crucial to the future health and life expectancy of that individual. Now, if that is the case, then actually taking your energy away from treating someone who's got mild hypertension, whom actually a few years ago wouldn't even have been diagnosed as having high blood pressure, and concentrating it on antenatal and postnatal care and childhood care, actually is the seed corn for the future health of your population. And if what we do is it's the old story about whether it's better to have a fence at the top of the cliff or an ambulance at the bottom. And if, in this case, it is much better to have a fence at the top, which is to try and protect the health of our population at the time when they're most vulnerable, and that we can do something about it. If what we're doing is saying to 50-year-old people, we must do something about your risky lifestyle, then that is the ambulance at the bottom.
Too little, too late.
And so actually taking this on, and if I can give you a concrete example. In Christchurch, which was devastated by New Zealand, which was devastated by the earthquakes recently, when the doctors there got together and formed what was called an IPA, they negotiated a fixed contract for drugs, for prescriptions, and for investigations, and then they rationalised their use of drugs and investigations, and actually made substantial real money. They weren't dealing with fictitious money. They actually had money at the bank. What do they do with it? As a community, all the GPs agreed they're going to invest in health system. And they put all their money, the extra money they had made for their from savings in their drug budgets, they put it into trying to make sure they weren't replicating the problems of today tomorrow. And that's where we're saying, if you invest there, you will get better bang for your bucks than treating cholesterol in 80-years, or treating cancer dramatically in 98-years.
Treating cholesterol in anybody over 80
You
years.
shouldn't treat cholesterol in 80-year-olds. Is that what you're saying? You shouldn't treat
No.
Yeah, well, there may be some circumstances, but by and large, no.
So is the old adage, prevention is better than cure, is it valid? Is it no longer valid?
It's so seductive, and we're only just being able to work out how ineffective it has been. Prevention is better than cure at the level of children and pregnant women, undoubtedly. But at the level of once you've had this disrupted neurodevelopment, you've got your it's called allostatic overload, where the whole system is overstressed from childhood and it's fixed in an overstressed mode. Trying to treat that with a drug when somebody's 50 and expecting that the quality and outcome framework of the UK would reduce health inequalities strikes me as naive and extreme. What it has done is reduced the health inequalities in the recording of blood pressure. Well, great. So poor people are now just as likely to have their blood pressure measured as rich people. Fine. But they're still dying much younger. Because it's too late in the...
Sorry, we're not saying no prevention.
No.
What we're saying is be rational. Because there has been an obsession with all prevention. And actually what we should be doing is concentrating our preventive firepower on people at highest risk who've got the most remediable risk factors. So looking at someone who is very obese with very high sugars and high cholesterol and saying, my God, their risk is high, that is well worthwhile concentrating on. But if you go to the margins and you start treating people whose risks are very low, what you do is medicalise them and from them and all the psychology. And what we should be doing is concentrating the preventive firepower on things that genuinely work and for people who are genuinely at risk.
So I'm glad you made that rationalising comment, but what I was going to say in defence of prevention is obviously the rate of death due to coronary heart disease has been in very rapid decline over recent decades. How would you account for that if it isn't to do with...
Oh, it's terribly interesting because the decline started long before cholesterol. So it seems to be very closely linked to smoking, but it's actually following the trajectory of a slow infection. It's very interesting. I mean, we don't understand why, but it's been a cohort effect that has moved through. So attributing, it's very nice for the drug companies to think that that it's to do with statins, but the trajectory was coming down way before that. It's like the decline of infectious diseases preceded antibiotics because of improvement in housing and sanitation, etc. So we don't know what has done that. Clearly smoking policies. Smoking was an absolute cultural disaster.
And still is. I mean, it's still 20% in I don't know what it is in Jersey, but it's still too high, and that is an area in which, incontrovertibly, trying to change behaviour, if you're successful in changing behaviour, has a wonderful return on investment. So we're not being nihilistic, but we're saying, in terms of cholesterol, the evidence for treating people with marginally raised cholesterol is not good. And the polypill approach, where you just put everybody on cholesterol alone because it's a continuum, actually is going to medicalise and damage more people than it would in terms of...
I don't disagree with that at all.
Mm.
And just comment on the QIF as it's currently configured and what you think it should potentially look like to add maximum value for that.
Well, I you should just incentivise the collection of data to start, so that you've got the GPs recording data. You've already got wonderful recording of drugs used. What you need is recording of diagnostic categories, recording of use of investigations and referrals. Get that information up, start analysing that information, see where you want to tweak it. Don't decide what you want to tweak before you've got the data in, because you may find you don't need to incentivise some of the things you think you might want to incentivise, because your GPs may be doing a fantastic job on that particular one already. Wait and see where the gaps are. Wait and see which is the group that is being referred to hospital disproportionately, because services aren't available in primary care. Get the data first, then decide what you want to do, rather than decide what you want to do before you have the data. That's what I think they should.
But it does require... Believing that just because the data's there it's going to be of very high quality is not our experience. It does require effort to get people to record things that they don't unnecessarily understand the implications of not recording well. And we were having many discussions last night about how some of these data quality issues arise. But unless people understand the implications of recording, for instance, a patient who's had a heart attack, recording a myocardial infarction, and then when they come back for review, recording a myocardial infarction again. Now, for them, they've seen them twice for one was the soon after and one was 6 months later. But what that looks like in the data is if the patient's had another myocardial infarction, right? And so it is until you sit with them and point out what the data implications of various recordings are, they don't understand and they don't get it right. Because for them, with the patient, they know they only have one myocardial infarction, and the fact that the record has it twice is of no interest to them because they know it's only one, right? They know the patient. But they need to understand that for the medical office of health and for the whole of the island's planning, it's absolutely vital to understand how many people have had myocardial infarction the last year. And that's going to be a monitoring issue. So when you start to deal with data, you need to concentrate on the quality of that data for a while and the way in which it's used within the clinical setting in order then to have confidence that you've got good quality data. And it took us several years to get up to the situation where you can then start to do commissioning and planning around using GP data. But it can be incredibly valuable when you've got it up to a certain quality. So you just need to think about that and not assume that just because you've got access to electronic records, what you get will be gold dust.
No.
What you get needs building on.
And that's the other answer about the collapsing epidemic of ischemic heart disease, is that, don't you remember, you used not to be able to allow people to die of old age. So when old people in their 90s dropped dead of something, you had to code it, and the most common thing was to code it as a heart attack. If an old person dies suddenly, may well not be, but you had no way of knowing. And now you're allowed to, certainly in the UK, you're allowed to certify the frailty of old age. So do you see what I mean? So it depends where your data's coming from, because some of it can be pretty dodgy, depending on what pressures you're putting on it. We're out doing that. We're overrunning these important people's time.
I think this is the moment, Zoe, to put them out of bed.
Thank you very much.
Thank you.